Multiple factors can affect how much drug actually appears in the body. Those factors clearly, such as adherence, if we don't take the drug, we don't have drug in the body. Food effects, whether you take a drug with or without food, can affect how much drug gets into the body. Comorbidities, the age of the patient, and drug-drug interactions are a major factor we have to consider. When we take an oral drug, the drug goes into the bloodstream and the drug has to undergo dissolution, it has to be absorbed, and it has to get to its target site. Through these processes, you can actually lose drug, and you can increase or decrease the amount of drug that will arrive at the target site by various factors. So food can be a factor. The pH of the gastrointestinal tract can affect some drugs getting into the bloodstream. And then you can upregulate or downregulate the amount of key enzymes. One of those key enzymes is cytochrome P450, which is present in the gut and is also present in the liver. And we have gatekeeper proteins which help getting drugs in or out of tissues. And those are called transporters. Now, all of those factors can influence how much drug, and this is the concentration of a drug against time in a dosing interval, all those factors can influence how much drug actually appears in the bloodstream. And we're going to be considering the importance of drug-drug interactions. So this is the issue we face. We need to get drugs into a therapeutic window. And so this is what we want to achieve for therapeutic success. As we give the drug, we build up the drug, and we have the therapeutic window, and that therapeutic window is key to the drug working. What you don't want is too little drug, because that is going to lead to therapeutic failure, or you don't want too much drug, because that could lead to therapeutic failure because of toxicity. And therefore, the effect of a drug-drug interaction could be to lower the concentration, therapeutic failure, or increase the concentration, which could lead to toxicity. That is why drug interactions can be so important, because of the effect they can have for toxicity or for a lack of therapeutic failure. So drug-drug interactions, the management concepts for us, some interactions are useful. So in HIV, ritonavir boosting is a very useful interaction because it increases the amount of drug. And we're going to have ritonavir boosting, as Jean-Michel mentioned, within HCV as well. Some interactions can be managed clinically, and that is the process of assessing the interaction and managing the interaction. However, some interactions are so profound that you should not give the two drugs together, so concomitant administration should be avoided. And some interactions, we really don't understand the implications, and therefore the interaction is of unknown clinical significance. So drug interactions in HCV is an important emerging topic. If you look at PubMed, where you can look at all the interaction data or all the publications, and we look over the last few years, very few publications on drug interactions related to hepatitis C. We come to 2011, and there were 10 publications, rather than just the 2 or 3 which had been in the preceding years. We come to 2012, there were 30 publications. In 2013, I estimate there will be at least 100 publications. So it's increasing the importance of this topic. Most of the publications in year preceding 2011 involve people talking about ribavirin and the HIV drug abacavir. Was there an interaction or wasn't there an interaction? I think that question was actually addressed at a CROI meeting, a retrovirus meeting this year, with a study which indicated that plasma ribavirin concentrations were actually no different when given alone or with abacavir. Previously, people had speculated that giving the HIV drug abacavir blunted the effect of ribavirin. I think the evidence now is that that is not actually happening in terms of this being a clinically relevant interaction. So there is no clear evidence of an interaction between ribavirin and abacavir. But clearly patients in the DAA era are taking many other drugs for cardiovascular disease, for malignancies, diabetes, psychiatry, opioid dependence, co-infections, transplantation. And we have to think about all these other medications that a patient may be taking, plus things that you may not easily know, but they could be taking from over-the-counter medications, certainly in many countries. So what is the issue? Tomorrow I'm going to talk more on a case study which involves some cardiovascular drugs, some CNS drugs, and some steroids, for example, and we're going to talk more about that tomorrow. But in principle, this is what we need to be concerned about. We have our directly acting antivirals, particularly now telaprevir, boceprevir, and we have co-medications. What are the interactions between those two groups of drugs? The major effect that we have been concerned about is the effect of the telaprevir and boceprevir to increase the concentrations of co-medications and therefore potentially lead to toxicity. However, that is not the only interactions. So we're faced with telaprevir and boceprevir, which are both metabolized by, and Mark mentioned it earlier this morning, the enzyme cytochrome P450 3A4. But not only are they metabolized by that enzyme, they also inhibit this enzyme. And I'll show you why that is so important in relation to understanding drug interactions. They are also transported by some transport proteins, which are important in getting drugs into the liver. Also, transport proteins are important in the kidney, and we're understanding more about these particular gatekeepers for getting drugs into and out of tissues. Now, this is why cytochrome P450 in the liver and also in the gastrointestinal tract, in enterocytes, is important. And CYP3A is the key enzyme because it is the most abundant enzyme if you look at the actual amount of enzyme in the liver. But it metabolizes around 40% of every therapeutic drug that there is. So that is why if you have boceprevir and telaprevir inhibiting this enzyme, potentially you can be affecting around 40% of all therapeutic drugs that are taken by patients. Now, here are some examples. Here we have two immunosuppressants. Here we have midazolam, and here the statin, atorvastatin. With telaprevir, cyclosporin levels can be increased nearly 5-fold. Tacrolimus, 70-fold. Midazolam, 9-fold if you give midazolam orally. And atorvastatin, 8-fold. With boceprevir, the interactions are the same, slightly less in magnitude. So we have to learn how do we manage clinically that interaction if you have a transplant patient with cyclosporin or tacrolimus, which clearly is more challenging because of the magnitude of the interaction. With midazolam, oral midazolam, the magnitude means it is contraindicated, oral midazolam, with either telaprevir or boceprevir. with the statin atorvastatin contraindicated with telaprevir, dose reduction with boceprevir. Now, they're just examples where we have clinical management and also contraindication, which means that we have to think about the drugs that are being used in conjunction with directly acting antivirals. So, if the clearance or the removal of the drug from the body involves just cytochrome P453A, the co-medication levels will increase, and we have to think, what does that mean? If there are other pathways that the body uses to try to get rid of the drug, then the co-medication levels could decrease, which makes it complicated. And there are other interaction mechanisms that we can consider. Here's one example of a drug decreasing in concentration. It is the antidepressant escitalopram. With telaprevir, it goes down 35%. With boceprevir, 21%. And that's because it's not metabolized by cytochrome P453A4. It's using another pathway, which is probably induced, and therefore you're getting a decrease. What about methadone? Clearly that's an important interaction. With methadone, you have an added complication, and I don't want to confuse people too much, but what you have with methadone is, and this is a study which was done with methadone alone and maintenance doses of methadone drug levels shown. With telaprevir, methadone levels went down, and you might expect an increase in the maintenance dose to balance that decrease in the drug in the body. In fact, what happens with this interaction is a displacement of the drug from its binding to proteins, albumin and alpha-1 acylglycoprotein, which, in short, and I could explain this, quite a long explanation, means that the unbound, not to protein concentration doesn't change, and you don't necessarily need to change the maintenance dose of methadone, despite seeing a decrease in the total drug. And boceprevir is the same, but we don't have the unbound data. You see a decrease in concentration of total methadone, which doesn't matter. And that's an interaction which doesn't actually clinically at this stage seem to be a problem. One question that we're sometimes asked is, what about ribavirin and telaprevir and anemia? And a study which was shown recently at the CROI meeting in Atlanta showed that in subjects who were taking dual therapy, that is PEG-RIBA, and measuring the ribavirin concentrations, and then triple therapy with telaprevir, the concentrations of ribavirin increased by a mechanism that we're not sure. So sometimes we're not sure of why there is an interaction. And the question then is that a part explanation of an anemia-related effect, which is with boceprevir and telaprevir? So in terms of management, we have relatively few drug-drug interaction studies. They're done in development, and some are done post-licensing. And therefore, we have to think about how are we going to manage it and respond to all of the drugs where we don't have actual clinical data. And most of the studies are done in healthy volunteers. So I just want to pose a couple of other questions. Firstly, in co-infected patients, HCV with HIV co-infection, some are predictable, those interactions, some are unpredictable. Don't forget now we have the added complication, not only of the HCV drug and the co-med, we have the HIV drugs, and we have a list of HIV drugs, and the co-infection means that there could be potentially an interaction between the HCV and the HIV medication. Here is a predictable interaction because Maraviroc is a drug, an entry inhibitor, which is metabolized purely by cytochrome P453A, and based on cyclosporin and tacrolimus, I expected it to go up. And what actually happens is that with boceprevir, it goes up about 3-fold, and with telaprevir, about 10-fold. So there is a predictable interaction with Maraviroc because it's metabolized by that enzyme. And the conclusion is you could dose adjust Maraviroc if you were going to use that combination. Probably rarely, but you could use it. This is rilpivirine, an HIV non-nucleoside reverse transcriptase inhibitor. It's a predictable interaction because it's metabolized by CYP3A, and what happens is that telaprevir increases rilpivirine, boceprevir increases rilpivirine, and that's what you would anticipate from that interaction. So you can manage an interaction where you know what is actually going to happen. What we were surprised about were the interactions, and I think Magnus will go into it more tomorrow, so I just want to mention it, is with the boosted HIV protease inhibitors, where we had a decrease in concentration. For example, of darunavir, this is a least square median ratio of the HIV drug, which went down by 40%, and telaprevir also went down in terms of its concentration in each of these boosted HIV drugs. And so what happened then was we had to say, don't use, or it's not recommended to co-administer these boosted protease inhibitors with telaprevir, apart from atazanavir, where the interaction is less. The same with boceprevir. Each time the HIV drug went down in terms of its concentration, 30%, 40%, and also the boceprevir went down. And so the recommendation from the FDA and the EMEA was that this would be not recommended apart from atazanavir, ritonavir, on a case-by-case basis. So we have complicated interactions which are difficult in this sense to completely understand the mechanism. The only thing that I want to point out is that in these subjects, ritonavir has already inhibited the key enzyme cytochrome P453A. That's what it's doing. So telaprevir and boceprevir are going to exert other effects in terms of what they're doing in the liver and the effect that they might have on the HIV drug. So I'm not going to go into that in any detail. My final points are, all of the interaction studies are done in healthy volunteers. What if the interactions were different in HCV patients compared to healthy volunteers? How can we understand what's happening actually in the patients rather than a healthy volunteer? Because we know that there will be differences in proteins. Albumin can change, alpha-1 acylglycoprotein can change, which can influence, for example, cytochrome P450 expression, and also the hemodynamic changes and shunting might mean that the interaction magnitude will be different in a patient than it will be in a healthy volunteer. And I think we're beginning to learn that this may be part of the explanation for some of the differences now seen in clinical data with HIV drugs in co-infected patients versus mono-infected patients. I'm going to skip a couple of those slides. Just go back one. Can I go back one? So, clearly we need help. I come from the city of Liverpool, and one of the only things Liverpool was ever known for was a group called the Beatles. And the Beatles had a famous song called Help, and I think we need help in order to understand drug-drug interactions, because it's not going to go away, and we have to learn how to manage. And we can manage if we apply some principles and learn how to manage. And therefore we need some web resources, And there are a number of very good web resources that we can highlight and look for and begin to use in order to manage these interactions. I'm just going to highlight the one that we run from our centre in the UK, in Liverpool. This is called HEP Drug Interactions, which is a database of all co-medications listed with, at this stage, telaprevir and boceprevir. And you can get it on your iPhone or your iPad or your Android, all free to download. And it gives you the information around these drug interactions. Now, in addition, the last point I want to mention is that we're going to start in June an interaction query service where anyone who has an interaction query can send it by part of the website and we'll have a response within 48 hours. And as the new drugs evolve, and here is just an example of tenofovir. There's also a section on the website giving all of the information around the new drugs and all the interaction data with those new drugs. So we hope that's a useful resource. There are other resources. I highlight the one that we run, but there are other resources as well. Thank you very much.